Misoprostol. When you see prostol, it makes you thinking of what? I'll put as a note here. Mathangi, prostaglandin, absolutely. And misoprostol is a PGE1 analog. And essentially the way we're going to use that PGE1 analog is pretty much as an antidote to aspirin-like drugs, so to NSAIDs-induced ulcers. Now, NSAIDs-induced ulcers, they share a lot of our patients with stress, having an issue with cortisol, with endogenous cortisol. It's just that NSAIDs have a more direct effect on prostaglandins because they block what key enzymes that are critical to prostaglandins, prostacyclin, and thromboxane synthesis. Cyclooxygenase, Sharon. These are COX inhibitors, so they decrease prostaglandin production. Misoprostol is there to replace it. One problem with prostaglandin analogs that we should always remember, well, first, as a main side effect, it can cause diarrhea with increased motility, but that increased motility of smooth muscle, unfortunately, you find it somewhere else. And tell me, what is it that we always need to worry about if we were to use misoprostol in our patient? Oh, well, I'm sorry. Who do you worry about when you have prostaglandin analogs? There's a big contraindication. Exactly, Anon. How are you? It's pregnancy. Because it would trigger an abortion. That drug obviously has a prostaglandin analog. So misoprostol, pretty much put it on the side. It's really considered an antidote to NSAIDs-induced ulcers, which is pretty unique and specific. Sodium bicarb, it's what we call an antacid. There are several antacids, so I'm going to put a note for antacids. Antacids in general. And of course, there's sodium bicarb, but there is also calcium carbonate. And calcium carbonate, in both cases, you're going to worry about the risk of bicarb or carbonates to be absorbed. And if bicarb is absorbed, what could be the acid-base disturbance you may have to worry about in the patient? For a side effect. You know, risk of metabolic alkalosis is a possibility. This is even further the case if you drink milk with it, so that then you get that milk alkali syndrome. Did you hear about the milk alkali syndrome? Whereby with a high pH there's greater absorption of the bicarb and then people can develop metabolic alkalosis. Now the other two antacids to know of, well, there's salts of magnesium, and that can cause diarrhea because it's also a laxative, and salts of aluminum, particularly aluminum hydroxide. So aluminum hydroxide and AlOH3 if you want that 3 times. Aluminum hydroxide, you worry about aluminum causes constipation. But maybe what's more important about antacid is be careful for drug interactions. This time, what is the drug interaction due to? with antacids? Tell me. When you increase the pH in the stomach, in the proximal intestine, what do you change in pharmacokinetic? It won't be metabolism this time. Let's see, Zaire. Tell us. I'll start writing. When we increase pH in the GI. Zaire, excellent. It's exactly right. Increasing the pH in the GI will increase the absorption of weak bases. So things that could end up in amines, but also drugs like quinidine, which is very cardiotoxic. If you remember when we did some cardio and antiarrhythmics and many others, but just to give you an idea, and will decrease the absorption of weak acids. So weak acids, drugs that end up in AIDs, like barbiturates, for example, but also warfarin is a classic weak acid. Phenytoin is a classic weak acid. Unfortunately, the chemists don't always give us an easy way for us to know whether you're a weak base or a weak acid. But when a drug has significantly low therapeutic index, you remember the therapeutic index, the ratio between the toxic dose in 50% of the population and the effective dose in 50% of the population. If that safety margin is narrow, well, then we always worry about those drug interactions since antacids are over the counter. So antacids, 4 major types, 2 with carbonates that can cause metabolic alkalosis, 2 salts of either magnesium or aluminum as metals. One is associated with diarrhea, the other with constipation, and yet all a big risk for drug interaction by altering the pH and making non-ionized weak bases, increasing their absorption, and ionized weak acids, decreasing their absorption. So that's good. Misoprostol, we had nothing else to say. We have the treatment for H. pylori. So the only thing we're going to say about the treatment for H. pylori for the 14 days is this is to decrease recurrence of ulcers and the risk of stomach cancer. And stomach cancer, generally adenotype of carcinoma or non-Hodgkin lymphoma, particularly mucosa-associated lymphoid tissue type of lymphoma, what we call a maltoma type of setting. So getting rid of H. pylori, which brings us heads on with those omeprazole and famotidine story. And I wanted to build another question with omeprazole. So